All right. Hi, everyone. This is Bethany Hamilton with the National Center for Medical Legal Partnership. Date's May 21st. We appreciate you joining us again for our learning collaborative on how to advance medical legal partnership in health centers. It's the 4-part series. We'll let as folks log in today. Got a pretty sizable number, and I'm going to attribute it all to our expert panelists who have joined us today. Has absolutely nothing to do with what I know of this subject, and that's why we brought in the folks who do know best how to talk about screening and information sharing for medical legal partnerships. This is a learning collaborative that is not just supported by HRSA, but we do focus quite heavily on health center MLPs. But we do think, however, our learning objectives and talking about MLP within this context is going to be translatable across the board. Any information can be applied to different contexts. So those of you who are joining us from healthcare organizations that are hospitals, perhaps you are from like family resource centers or otherwise, you should find this information applicable. So what is our objective and our aim for this learning collaborative? First, as you know, we went over before, we're diving deep into select components of medical legal partnership, and we're going to help you as peers, because some of our, and not some, our subject matter experts that have joined us here today are in fact your MLP peers in the field as well. But we're going to work together to help identify some specific challenges, as well as best practices for screenings, identifying and then referring patients to the right sources to address their legal needs. And then what does information sharing look like? How can we overcome some of those challenges and apply best practices from around the country that we've discovered over the years of doing this? Then we'll help you establish along the way some sort of consistent and sustainable financial bases for supporting your MLP programs, or your advanced or otherwise. That's what we'll hear about in some future sessions. And then, because we're connecting you with peers, not just as participants, but also with these subject matter experts, we're hoping that there will continue to be some continuous learning so that you can continue to build successful MLPs for the populations that you're serving. All right, so where have we been in session 1? I did an overview for those of you, especially who are very new to medical legal partnership. I did a quick well, maybe not so quick, an overview of medical legal partnership. What is it? And then we went into a breakout session about these select components that we're looking at. First, what are the social determinants of health that you are going to be addressing for the specific populations that you're serving through your MLP? Then we selected a separate conversation. All of these come from the Health Center MLP Toolkit, but then we went into a breakout room about building it, right? Do you contract out or do you build it right in for your legal services? There was another breakout room that talked about how to pay for it. That is the big question, and we'll go into that with a separate session about how to pay for it for specific populations, or with specific populations in mind. And then today, this is where we'll go into that deeper dive conversation that the breakout room for conversation number 8 talked about, which is screening and information sharing. So that's where we're going today. The subject matter experts that were joined by today are David Falmo of Siouxland Community Health Center, Erin Planout, who's with Iowa Legal Aid, Shannon Pohl with Alliance Chicago, with whom we're partnering on this initiative, and Mallory Curran, a longtime MLPer, who we've continued to consult with to tap into her legal tech guru brain, as I like to put it. Please, we welcome them all as they present today. I encourage you all to please, please, please live chat your questions for them, your comments, your experiences. And with that, we'll kick it off so that we have time for engagement. Thanks, everyone.
Great, thank you so much, Bethany. I'm Mallory Curran. It's really wonderful to be here with you all today, both our audience as well as the other faculty members. Before we jump in and get started, I'll just give you a quick mention about what we're going to be talking about, which is both screening and referral and closing the loop. So I shouldn't say both, I'll say all of those things. We're going to talk about screening in the EHR, referral in the EHR, and closing the loop also in the electronic health record. And that's going to be featuring our partners at Siouxland Community Health Center, Iowa Legal Aid, and then Alliance Chicago, all of whom are represented here today. And they've really been the pioneers in putting this together. And there's a lot of opportunity for other MLPs to start doing more in their electronic health record. We're very excited to be the pioneers, but also the teammates have always wanted me to say that we're not saying that these are best practices, that this is definitely a work in progress, and we're all learning as we go. So it's not, this hasn't been a one-time event. It's been an ongoing journey, which will continue in the future. So we're really interested to hear later in the call a little bit more from those of you who are participating in the call, what the types of things that you're working on, what are some of the opportunity and challenges, and really have that conversation about where we want to go as a network. All right, and we're going to do some live, Dave Faldno at Siouxland, and then Aaron, we're going to use Siouxland's electronic health record to do some live demonstration of what it looks like on the clinician side, and then also show you what it looks like on the legal team side. Okay, and I'm going to turn it over to my co-panelist, Shannon Pohl, to talk a little bit about why we're here today and why we think that this work that we've been doing is so important, not just in Iowa, but throughout the MLP network. So I'll turn it over to you, Shannon.
Thank you, Mallory. Can you guys hear me okay? If I could get some head nods. All right, great. Always got to check on these virtual meetings. So good afternoon, everybody. I'm Shannon Pohl, Director of Informatics at Alliance Chicago. I think when we were first thinking about how we wanted to carve this session, I think it's always good to start with the why, right? In terms of how to and why to engage the technology solutions that are available for a medical legal partnership. Certainly access and communication, these solutions can enable kind of the resourcefulness in the communication to ensure all that the necessary stakeholders involved have access to the information without barriers. So certainly on the health center side, the providers and the care team, and then as well on the legal partner side, and then certainly last but not least, but also the patient, the patient having, seeing that the access is happening also helps, which kind of leads to the next point of automation and efficiency. So how can we use technology to minimize those manual steps that would take additional resources to do? I think we're all thoughtful of the national problem that's happening with healthcare providers and care teams overall on that issue of burden, of that there's a lot of steps happening right now in healthcare that feel burdensome and feel manual. And I'm sure on the legal partner end, I'm sure you have some similar workflows as well, where you're feeling burdened. So how can we automate? How can we make more efficient the communication that is happening around the patient and the client? And then lastly, continuity of care and patient engagement. I think when the patient sees that technology can be used and that the health center and legal partners are actively engaged in investing in technology so that the patient doesn't have to advocate for themselves, that you can use the technology and that they have stakeholders around them that are pushing for advocating for their health harming legal needs, that has a downstream impact in terms of the next time that they want to seek care or seek help when they need it. If they have a positive experience in this sort of specific effort as part of the journey, perhaps the next time that they would engage again. And I heard this on session 1, is that how do we drive engagement? And sometimes there's active actions that you take, and then sometimes it's passive as well, that seeing the technology solution that's enabled can help for that. If we go to the next slide, I'm going to first talk about some social determinants of health screening tools overall that are available. And these, I just want to stress, are overarching screening tools for social determinants of health. And we'll talk about how you translate that to health harming legal needs in just a little bit. Certainly one that was mentioned on session 1, through a partnership with the National Association of Community Health Centers, APCHO, Oregon Primary Care Association, and the Institute for Alternative Futures is PREPARE. Now, PREPARE is an acronym, the protocol for responding to and assessing patients' assets, risks, and experiences. So that's PREPARE. Doesn't really roll off the tongue if you say all the words there, right? So that has been a great national effort in order to identify a patient's risk on what's going on in terms of not only health harming legal needs, but certainly food insecurity, transportation, do they feel safe at home, et cetera. So that has been a primary SDOH screening tool of choice for many healthcare organizations. Another one that's available out there is released from the American Academy of Family Physicians, the Social Needs Screening Tool. And FYI, if you did not see already, these are all hyperlinked for your convenience when you have the slides as well. Okay, so this, you'll see the AAFP version. There's a lot of overlapping questions if you kind of compare with the PREPARE tool, that there's a lot of the similar topics there. It's just maybe perhaps worded in a different way. And then certainly the third tool that's available there as well from the Centers for Medicaid and Medicare Services, the health-related social needs screening tool. I think you'll find in all of them that it's going to be dependent on your workflow, how much time that your providers and your care teams have in order to do social determinants of health screening, who's doing it, the familiarity with the topic in terms of the tool that you choose. We have also found in a lot of our health center organizations, and certainly I'm sure in hospitals, I don't want to omit the hospital and inpatient experience as well, that there are a lot of homegrown tool development also for social determinants of health screening, which is A-OK. We've seen, I think especially with the COVID-19 pandemic, we've seen an increase in homegrown where they wanted to take perhaps a narrower lens of one of these standardized tools as they pivoted towards the pandemic. And then we have others that maybe they did a narrow tool because they wanted to opt into one of these larger standardized tools. You know, I think whenever you're thinking about a homegrown tool development, you want to just think about overall, are you talking about it as a team? Are you not just choosing it because it's been there for a while, but what's the rationale for using a homegrown tool versus one of these vetted tools? I think the benefit of the NAC, the AAFP, and the CMS tools is that they've been vetted by a large amount of peer review. So, and there's research associated with them as well. So determine why you're doing a homegrown tool on what's more successful for your patient population versus one of the standardized tools. And then you also have to think of the downstream impact about when you're doing a homegrown tool, especially if you're engaging technology, what's involved with the maintenance, what's involved with the support, is there cost involved for resourcing it? And then if you want to iterate on it further, because we know it's very fluid, sometimes these screening tools have to change in order to adapt to the moment. So are you ready for maintaining and iterating on that over time? And what you'll see in the ongoing presentation is that whatever is chosen, these are overarching social determinants of health tools for overarching SDOH needs. And there's going to be an element of translation that you do in the workflow and in your processes on how you translate those to identifying health harming legal needs, which you'll see in the demo shortly. Okay. So if we go to the next slide, I'm going to hand it back over to Mallory to describe the project that we've been experiencing over the past couple of years.
Thank you so much, Shannon. So I want to recognize the Legal Services Corporation, which is a major funder of legal services in the United States. They awarded Montana Legal Services a technology initiative grant. So we worked on some projects in Montana, and then the Iowa team was an equal partner in that project. And again, today we're focusing on the Iowa side. And as I said earlier, we're going to talk about this in 3 different pieces. One is screening in the electronic health record. That's what we're going to talk about first. Then we'll come back and talk about referrals inside the electronic health record, and then finally closing the loop. So we've mentioned this before, but our teams are the team members rather are the Iowa Primary Care Association, Siouxland Community Health Center, Alliance Chicago, which is really a health IT guru. They're a HCCN, and then Iowa Legal Aid. And at this point, I'm going to turn it over to Dave Feldmo to talk about his experience with putting together the screening tool, his experience both as a clinician and an administrator, and also a very early adopter of Prepare. So I'm going to stop my screen so that Dave can share a live screen with us.
Okay, can you hear me okay?
Yes.
All right, good. So again, my name is Dave Feldmo, and I'm a practicing physician assistant, but I also serve as the quality director of our organization. So I've been involved with Prepare and the medical legal screening work that we've been doing for a long time. It's been really exciting work for me as a clinician and as a quality director to be involved in this work. So I just wanted to show briefly, so this is a test patient's chart, and you can see all the forms that we have to go through in a patient's visit. But this is our legal screening form right here. And it's got the different tabs across the top of different categories. And sometimes the screener might have questions on what that really means. And so there's these little question marks here where I can click on that, and it kind of gives a description of what you might want to ask for here. And then if you do click on one of these, it breaks it down a little bit more as far as what the problem actually is. And so then you can click on here and then maybe put a comment, and usually put a comment in here that will, again, once we make the referral, will go to the legal aid office so they have a good description of what they're going to be dealing with. And so all of these, they'll have the same functionality. It's got the help button, and then again, if you hit yes, it's got the different options of what you can check and make the comments. And so this is part of our social determinants of health screening, and there's jump buttons. And so, you know, if I'm in a chart, usually here's the history of present illness. It's got a jump button where I can go right to the Prepare, which is the social determinants of health screening. It shows if they've been screened previously, it'll show me what was the results of the last screening. And then these next tabs will go back into it. And some of these things are auto-populated as far as their address, their ethnicity and race, if they're a veteran, their household income, and how many people live at home. And then the rest of these, you know, we can fill out ourselves. And as most of us know, many social determinants of health do have a legal solution perhaps to what's going on. You know, they can't afford their medicines because their wages are getting garnished, and should be. And so that's kind of how we approach it. But we felt strongly that, you know, even though we're screening for these social determinants of health, we needed a question about legal services. And the way we screen, we have a paper form that we actually do the screen on most of the time. And it has all these questions in Prepare, but it also has some examples of maybe some legal needs that they might have. Because if you just ask someone, do you have any legal needs? A lot of times they won't know, you know, that they do have some needs that they didn't know that there might be a solution to. And so if we click yes on that one, it pops up and I can go right to the legal aid screening that I showed you before. So, you know, we really encourage our team to be specific in these comments to make sure the legal aid attorney understands what the referral's for. But it's just really nice to have this right within the visit as you're visiting with the patient to document right there and then what's going on to make sure you're not missing any details.
Dave
Great.
and Mallory, before you transition, can we see if Dave's able to zoom in at all on his screen, just so we can so folks might be able to see on that last one, at least some of the text that was just previewed, if possible. I know the EHR is limited. If not, for the audience, we know it's really tiny. I have really bad vision, so we'll try to get screenshots if possible as a follow-up.
Yeah, I am not sure how I would magnify it.
No problem. Okay, thanks.
Yeah, and we do have screenshots that I'll run through. But Dave, if you wouldn't mind, for example, if you could just read that question at the top about the wages, and then if you could also pop up the question and read what it says.
Sure. So it says, are your wages being garnished, or do you have concerns about debts? And so as I click that, it says patient might describe these problems as having money taken out of their paycheck to pay off debts, receiving harassing phone calls from debt collectors, being sued in court by a creditor, such as a bank or credit card company, or feeling overwhelmed with debt. Areas of law include bankruptcy, debt collection, predatory lending, unfair, deceptive sales practices, or unpaid and underpaid wage claims.
Thank you, Dave. So for each of those screening questions, which are organized by iHelp category, each one has its own question. So the clinicians are able to get a little bit more background info or have some additional questions to prompt when talking to a patient. Thank you, Dave.
Yep.
So Dave, if you can stop your screen, I'll pull back mine. So this one is a little bit larger, so you can see this is what we were just talking about with the, are your wages being garnished, or do you have concerns about debt? And then this is a pullout of what the question looks like. And then also another thing Dave had done, if he said yes, that the wages were being garnished, it gives him the opportunity to specify what type of problem it is. Is it debt collection, creditor harassment, or so on? He can choose an additional option, but he doesn't have to. Those of you on the legal team, these additional checkboxes are directly correlated with LSC legal problem codes. And then Erin, do you want to speak just briefly, Erin Planalp from Iowa Legal Aid, prior to us moving into phase 2 and doing internal, or rather electronic referrals, this is the type of form that would be faxed over to the Iowa Legal Aid team.
Yes, thank you. So as has been mentioned, we were operating in the paper world before we took the next step to streamline the referral process. So what you are seeing is the form that was generated once that legal screen was completed. So we identified kind of the key things that we needed on our end to open the intake, start it, and follow up with the patient. And like Mallory mentioned, I guess I wanted to say a bit on that too. The way that we wrote these screening questions that the healthcare staff could use was it was deliberate. So we took our LSE problem code list, which we have categorized into iHelp. Then we could try to lump them together and come up with as short of a list as possible of plain English, non-lawyer questions, just to make it easier on their end. But also then as they're sending the referral back, it's easier for us to open up that intake.
Thank you, Erin. Okay, so I just want to refer back to things I know you talked about on the initial session and put in another plug for the toolkit that was talked about. So you can see the front page there. The official name is Bringing Lawyers Onto the Healthcare Center Team to Promote Patient and Community Health. While this is designed for health centers, it's really broadly applicable no matter what your practice setting is. And I just wanted to point out that in part 2, there's a very specific section about implementing workflows for screening and legal services. So if you haven't downloaded this document, you should, and take a look at part 2 after what we're talking about today. And again, there's also very specific questions about screening. Okay, I'm going to turn it back over to Shannon, and she's going to talk a little bit about a readiness check, and then we're going to have you all speak up via a few polling questions.
Great, thank you, Mallory. So, thinking about your readiness degree in terms of documenting social determinants of health and then legal needs as a result into the electronic health record, I think we just wanted to outline just specific things to be mindful of as you go on this journey and to implement further and to increase the success. First of all, as a team approach, I think the core of a medical legal partnership is a partnership in a team atmosphere, so this is nothing new, but we want to be mindful of all the people that are engaged, so representative, not just from the clinical and the legal partners, but also certainly operations. So operations at both on the legal side and on the health center side, just to make sure that any sort of downstream workflow implications are recognized and surfaced. EHR and technical approach, certainly if you're engaging the electronic health record development or any sort of additional technical development like an app or something like that, or a third-party software that you want to engage those resources to see feasibility and cost. And then care coordination staff, we're mindful that sometimes this work doesn't happen real time when the patient's with the provider, that sometimes it's those in-between moments when they're present in front of a provider as well, that those sort of connections to health harming legal needs can be identified in care coordination as well. Screening tool we talked about, so what tool are you going to use? Make sure everybody's using the same one, all right? That would be a recommendation there. And then translation, so you saw an example about at Siouxland about how they translated what they did in Prepare and how that navigated to the legal screening questionnaire in detail. So how are you at your health center organization or hospital organization translating that screening information to health harming legal needs to act on? Workflows, so what are you trying to achieve? Is there a specific hot topic that is surfacing amongst your patient population that you want to hone in on further, for which you may want to do more active steps during the patient experience to target? And then how is the patient's information protected and kept safe? So overarching through it all, how are you keeping the patient's information safe? Data, so I think there's always an increasing need for data on both the medical and the legal side. So what things are you identifying to track and report on? Technical development, so with technical development specifically, a lot of it is on feasibility and then what limitations and opportunities that you have, and then who are the necessary parties that have to be engaged. You'll find, especially as it relates to the EHR, not every EHR is the same, and some people, they allow more flexibility in terms of the development. Some require third party, some require vendor. So the vendor of that EHR to be engaged, it just depends on what you're using and where you want the information to be. And then what's your budget? So thinking about the costs involved to enact this workflow and enabling the resources of the team to execute this project. So if we go into the next slide here, we have some polling questions. All right, so you should see a polling question number 1. Does your MLP screen for unmet legal needs in a systematic way? The answers are yes, no, kind of, and I have no idea. So we'll let those come through. And I'm seeing some answers across the board here. All right, so we got about 67% participated here. So the more, yeah, it's pretty much spread, you know, yes, no, kind of, and I have no idea. So if we could go to the next slide here, or the next poll, excuse me. And then, does your MLP screen for unmet legal needs in the EHR? Okay, so different from number 1. Number 1 was talking about a systemic way, or systematic way, excuse me. And then number 2 is talking about specifically in the electronic health record. So looking like we got a majority of no, and then yes, sort of, and I have no idea as the next questions there. Very interesting mix there, you know, and I think I could probably ascertain why as we get to kind of the next questions here. So kind of going into this a little bit deeper, if we think about this topic as a whole, if you could put into the chat or speak up, we are happy to have either or both. What has been kind of the easiest topic to tackle, what you've seen so far in coming to screening for legal needs in a systematic way? What has been the easiest part of the journey so far? And I'm going to monitor the chat as well.
Shannon, an interesting note was made in the chat by Wendy Asher about what her FQHC partner does. Wendy, I don't know if you want to unmute yourself to share. We do have a few folks who are only logged in by phone, so it would actually be helpful if you unmute.
Absolutely.
Because they can't see the chat. Thanks.
Gotcha. Hi, and your face. I've been
Hi.
playing with the Zoom allocation. Your face is giganto right now.
Oh, if anyone is like that, go to view.
No, I know.
And go to gallery view.
It's just I've been playing around with it to get a better handle on Zoom, because we're going to be using it for an all staff event next month, and
Good luck.
we want to be able to, I know it's like we don't do enough Zoom. Anyway, so our partner is El Rio Community Health Center. They're a federally qualified health center, so they're on board with using the Prepare tools. And a couple of years ago, they actually loaded those onto handheld computers so that the folks who feel comfortable answering those questions on a tiny little, it's kind of like the size of an iPad. I don't know if they're actually iPads, but it's about that size. So it's like, you know, like 5 by 8-ish size. Folks who feel comfortable answering the questions on that, their data gets put in immediately. And I actually haven't been monitoring the quality of that data or how that's going and getting feedback on what people put in. But they are using that tool, both mechanically and the actual data collection. And part of the logic for doing that was that after several of us had been at MLP national conferences, there was a strong argument for using the same tool because that allows data to be shared more easily. So if, you know, I'm over at another qualified health center and I'm making it up, I may be collecting excellent information, but then sharing that information across programs and across geographic areas becomes problematic. So they're doing that. They do a screening with all new patients, and they are doing a screening annually, at least with existing patients. So they make sure that at least once a year when somebody comes in, they're doing that as part of their sign-in process. One of the other things that we do as part of our partnership is we do monthly trainings with medical providers. They have regular lunchtime, they call them lunch and learns. So we're scheduled for like an hour every month. And that lets us do some training on some specific legal issues to help the medical providers and anybody else who wants to sit on the training be better skilled at issue spotting. Not that they're going to tell their clients how to solve their patients how to solve their legal problems, but they're at least going to be able to recognize. And, you know, we've all had examples of, you know, asthma and rashes and things like that that are environmentally caused. And so no matter how much the medical provider addresses the symptoms, if the person is still getting reinfected and re-exposed because of something going on in the home, that's not going to resolve the issue. Same issues with family law matters, domestic violence, screening for those things. We as the partner who are an LSC affiliate have the ability to address a lot of those issues for their patients. Does that was a long answer, but did that help?
No, yeah, you're an MLP peer. This is where we're bringing peers together to really share, right, their best practices or challenges. In the chat, Shannon and Mallory, do we have time for Steve to also share? I really like that. I just want to call out the fact that Wendy noted something that I don't know how much this is being done, but that annual screening, in the same way one would have like an annual checkup, they're doing an annual SDOH checkup. So I think that's, at least for me, that resonated. It's a great takeaway in addition to everything else that Wendy shared. I appreciate that, Wendy. Steve, do we have time for Steve to quickly share what he had
Yeah,
in the chat?
I think we have time. Yep.
Okay.
Sure. Hi, so Steve Weiss, Bay Area Legal Aid. We have a few different MLPs. We have two smaller kind of traditional MLPs that are with health partners. One is with community health centers in Alameda County. One is with the county health plan in Contra Costa County. And they both are funded through Medicaid waivers and pass through some of those funds to us. And they use Prepare, and they have the screening tool in their electronic health record and refer us for all civil legal needs. And then we have a larger, what Ellen Lawton called an atypical behavioral health MLP, so which is they refer a lot of people to us specifically for disability benefits through behavioral health care, and then we screen for other civil legal needs. So we have kind of a mix.
Hope the atypical becomes typical, Steve.
Hey, it's a good model. I'm preaching. If anybody wants to hear the sales pitch, it works.
Yeah,
It saves the county money, so they just invest more and more.
That's right. Especially with a Medicaid investment, it's really key to be able to show where the dollars are going and how it's saving the state money. And in California, it's right county by county. So you're really showing at the very local level, and then they'll feed that information back up to the state. So it's key to show the impact. If folks are, since we are talking about special populations and needs and screening, Steve highlighted the specific disability benefits advocacy. So for those of you who are forming or working on MLPs with that need in mind, Steve is on. Feel free to chat. I would encourage you all. We'll get an updated reg list and table so that you guys can do some peer-to-peer matching amongst yourselves. So Shannon, Mallory, Dave, and Aaron, I will stop interrupting, but thank you, Steve.
Oh, no problem whatsoever. It's a collaborative for a reason here. I want to be mindful that there were some questions from session 1 on how you do referrals and closing the loop. So if it's okay with everyone, I think if there's any sort of lingering questions or any experiences that you want to share, put those in the chat and we can certainly perhaps table them for the end if we have time. But I want to be able to show the next step of our project, which may be fruitful for people here. Okay.
Thank you, Shannon. Okay, so like I said, we're going to talk about 3 things in the EHR. One was screening, so we're wrapped up with that. The second thing we're going to talk about, as it says here, is making referrals from the EHR, and then we're going to round it up with closing the loop. So making the referrals is actually the quickest on the healthcare side. So we're not going to have Dave show his screen. We're just going to use this screen for Dave to explain what we did, what we added in order for his team to be able to make the referral. At least on the clinician side, very little changed.
Yeah, so at the bottom of each of those, no matter what tab you're on, at the very bottom, there's that little box you can click. And to get written consent, there's also another tab on the form where it says print referral letter. And so once you print that referral letter, have the patient give consent, then you can click that box, and that's what sends that referral off. And you kind of saw the form before, but this kind of what it shows. It also has a spot to say if it's safe to call whenever, and if they need an interpreter. So it's got some other information on there as well. So that's what we have the patient sign. And then that's put into the chart as well. So that's indexed or scanned into the chart, the electronic medical record.
Okay. Thank you, Dave. The next thing we're going to pop into is actually what it looks like on the legal team side. So really, there was a lot that happened behind the scenes in order to make a referral get sent over to Iowa Legal Aid. But from the clinician standpoint, they just needed to do an extra click. And then Erin Planout from Iowa Legal Aid is going to talk just briefly about what it looks like on her side. So I'm just on this screen. Oh, sorry, here, let me make it bigger for you. They manage online intakes in their case management system, which is called PICA. So all of the referrals that are then sent over by Dave and his colleagues go directly into their case management system. And then I'm going to pull up a demo site so we don't accidentally show anybody's data that we shouldn't be showing. So just one moment here.
And while Mallory's getting that pulled up, I'll mention that we already had an online intake system integrated into our case management system. So it was a pretty easy lift to just funnel these into that same kind of holding pen. So what you saw on Mallory's last screen was the holding pen where we can pull these referrals as they come in. The data points that were on that printed referral sheet that we showed before are now just coming into our notes section. So it's all right there. And that was, I believe, just a more practical option than trying to get the data point on the EHR side to directly feed into our data, our fields on the PICA side. And it allowed for some flexibility as well. So we're getting all of that information directly in there. And then on our end, we are also tracking more relevant data points so that we can report back in a more meaningful way. So this is one spot where we, once that intake comes in and we've connected with the patient and we've completed the intake, and now we're passing them off to an attorney within our program to speak with them. We check that, and then we can send a quick report back to Siouxland, just letting them know, yes, we got them, we've connected, we'll take it from here. The nice part about that too is it's a quick feedback to let them know also if there was some issue where we couldn't speak with that patient, so we can address that.
Great. Thank you, Erin. So we know that being able to do a referral is really important, and that was a big piece of what we did on the tech side, but we expect that a lot of people on the call, what you're really interested in is how do we close the loop on the referral? How does the team back at Siouxland know what happened with their patient? So Erin started talking about that already in terms of being able to let the clinicians know if they if Iowa Legal Aid was able to connect or not. But we'll also have her now talk a little bit about what she's able to show when they close out a case to let the clinician know what the ultimate outcome was for the patient.
Thank you. So yes, we're trying to close the loop at 2 stages. The first, to let them know that the referral has been received, and then when we are closing the case, we want to report back to them on the case outcome. So what we did is we came up with this template report, just trying to identify the key things that we really wanted to report back to them. We're obviously not going to data dump everything that we've collected from the patient. And part of that also is our release that we get from the patient so that we can report back. We have to be specific when we are asking them, what data are you okay with us sharing? So this is what we've narrowed it down to as kind of the key highlights that we want to make sure our partner knows about.
Thank you, Erin. So now we're going to bring Dave back in to talk about what he sees. So we're going to talk about how Dave knows that there's information related to one of his patients, that he's in fact getting an update, that the loop is starting to close on the referral. We'll have him talk about that using these slides. And then he'll show you again, I'll stop sharing, and he'll show you in his site 2 places that we felt it was important for the clinicians to be able to refer back and see that data that we showed on the previous slide. So Dave, can you talk about this slide, what you see when you have information related to a patient coming in?
Sure. So after the legal aid attorney accepts the referral, that first top document says result of legal referral. And so that tells us that it's been received, and we sign off on that, and that's part of that patient's chart. And then that second document just below that, the legal case outcomes, that will have additional information once the case is closed of the outcomes. And it's just a brief summary of what happened with that case. So we know that the loop has been completely closed and that case is closed, and we know what the outcome was.
Yeah. And one thing I'll mention too, from a workflow standpoint, is we made a decision to have the information come back into the provider who made the referral, not the primary care provider. So it's the person who had the closest communication with the patient about the referral to Iowa Legal Aid. That's the person who's notified. Dave let us know, you know, there may be many situations where he didn't necessarily know that his patient had been referred, and that it was better to have that notification go back to the person who entered the referral. This is the other document that Dave had mentioned. You can see here that he can see basically some of this information, veterans benefits. It says here that obtained, preserved, increased veterans benefits. It's enough to let him know, yes, this is my patient. I want to pull the data in, but we wanted to build out 2 ways for them to view that information. That was a little bit better. So I'm going to stop my share so that Dave can show you a history view for a test patient.
Okay, let's see here. Can you see that okay?
Not yet.
Is it
There we go. Yep, now we
Okay.
can see it.
Okay, so one place is just, we have a history view, and there's different types of history views. You can see at the top there, it says the Alliance Legal Services view. And so you can see any referrals that have been made. And so these are the referrals up top. The case information here is when it was accepted, and then the case closures are down at the bottom. And so again, it's just a brief synopsis of what happened to that referral and where is it at this point. And then once it's closed, you can see the case closures at the bottom. The other place we can see it is is right here on the legal aid form. Can you see that okay?
Yeah, we can see kind of the shape of the form. And I'll just say for people on the video, this is the same data that we had showed you that comes from Iowa Legal Aid.
Yeah, so it's basically the same information in a different form.
Yeah. And the reason we decided to put it in 2 places is that, one, the screen where Dave is now, which is the same screener, the same legal screener. So if he's in with a patient, he can both look at the history of the screening that he's done before, others have done before. He can do new screening, but he can also click on that case information tab to see, have referrals happened in the past? Has the person connected with Iowa Legal Aid, and have any cases closed? And then we also did the history view so that Dave could go in, he wouldn't have to have an open encounter. So the patient wouldn't need to be there that day in order for him to be able to go view that information. So the history view can be viewed any day, whether an encounter is open or not. And then the tab within the legal screener is able to be viewed when there's a sort of an active engagement with the patient. Okay, great. Thank you. And we really, we were really excited about being able to close the loop. We were excited about the concept of doing the referrals. That's something that's really easy to understand. And of course, we want to do that. But it was more challenging in a good way to figure out how to do this close the loop piece. And that's what I think has been really innovative, and why it's been so nice to work with the Iowa team, because they're so thoughtful, and the Alliance Chicago team, because they're so thoughtful in their approach. Okay, let me share my screen again. So here's that history view that Dave was showing. It shows legal screening outcomes like we talked about. The case information is the information back from Iowa Legal Aid about whether they connected or not. And then the case closure is what happened for the case. And the idea is that the 3 most recent referrals and the 3 most recent cases closed would show up. And there again is that case info tab. Okay, so briefly, Shannon's going to talk about translating these needs to the EHR, and then we're going to do another polling question and open it up for some more conversation.
Great, thanks so much, Mallory. So, this is just kind of the 10,000-foot view slide about what it takes in order to translate all of that into a technical and human workflow solution. It certainly stakeholder meetings with everybody involved, mapping out the workflow from start to finish, and then how the information comes back, doing prototypes You know, we're trying to be thoughtful from a human-centered design approach about what's best for the patient in this experience, and then what's best for the health and legal partners involved. So if we go into the next slide, doing a readiness check for, are you ready to make referrals? I think, Mallory, are you doing this one? Or
Yes,
is
I
that
am.
me?
Nope, I am. So we're actually going to go through what we think are the 3 key questions for this readiness check on our poll. But I also, we included this really nice flow chart as another plug to use the Health Center Toolkit that we mentioned at the beginning of the hour, as well as the same one that you talked about for the first session. So there's plenty of things to help you have a conversation with your team and to think about. But let's go ahead. I'm going to stop my share, and we're going to do what I said, sort of the 3 most important questions, I think, for are you ready to start sharing data electronically? Okay, so the first question is your electronic health record system API ready? And we have the same options again, yes, no, sort of, or I have no idea. And we still have answers coming in, but heavy on the I have no idea. Great. And April, you can go ahead, yep, and close it out and share the results there. So a couple people said yes, their electronic health record is API ready. 2 said no, 3 sort of, and then 14, I have no idea. That's about what I expected. So part of the reason that we asked this question is that we want you to figure out what an API is. So I'll just tell you, the API is really the sort of the mechanism by which 2 different systems talk to each other. In this case, you need to have an API or some sort of way to exchange data between the electronic health record and the legal case management system. So you can do a little bit of Googling and learn a little bit about that, but your electronic health record needs to be API ready in order to do that. And so you might think about, wow, I don't have a lot of friends in health IT right now. I need to get more friends in health IT. I'm fully supportive of you making better friends with folks in health IT to help you answer that question about your electronic health record. And as Shannon mentioned, electronic health records are very different from each other, and some are ready to go and others are not. And so you need to figure out where the healthcare team's electronic health record is in terms of like, can we even start walking down this path? Okay, thank you, April. If we can go on to the next slide, or the next polling question. Okay, is your legal case management system API ready? Yes, no, sort of, I have no idea. So again, the API is really sort of the mechanism by which the information flows back and forth. It's kind of like making a phone call. You need somebody on the other end to pick up your call. Otherwise, you cannot communicate via that phone call. And so the legal case management system needs to be able to pick up the phone call and receive the data that you're trying to share. Okay, and we're getting similar answers in terms of a lot of people have no idea. Some people know for sure it's not. Some people know, 1 person at least knows, yes, theirs is ready. So again, Aaron's team works with the PICA case management system. We worked with a really great programmer, Ty Acker, to help us build everything out on that side. But we needed to have a programmer work with us on that. A lot of people I know use Legal Server. I would say that Legal Server is sort of API ready. It has a lot of basic API capability. We would probably need to work with them to build some things out specifically for the medical legal partnership, but they would be ready to work with us on that. And then other systems, they're not ready and they're never going to be. I don't know if anybody on the call uses Salesforce-based database like Justice Server. Steve does, and I don't know for sure, but my guess is that they would be sort of API ready. Okay, thank you, April. And then our last question, and this is really getting at what I had said before as well. Is your health IT team or your health center controlled network, HCCN, available to assist with planning and implementation? So we would be nowhere on this project without Alliance Chicago. They've been 100% a key player in this project. If they weren't, or we didn't have an equivalent health IT team or HCCN, we couldn't have done any of this. So this is a little bit more, the responses that are coming in are a little bit more across the board, mixed between yes, no, sort of, and I have no idea. So again, I hope this is getting you thinking about, well, who do I need to talk to see how we might begin this journey with our MLP. And again, you can't begin the journey without your health IT team or HCCN on board. So we're encouraging you to think through who you need to make friends with and who you need to invite to the table to have this conversation. Okay, so then a couple of questions that we wanted to open up for the conversation. And does anybody on the phone have any examples that they're able to share with us about electronic referrals or electronic closing the loop that your MLP is using or hoping to use in the relatively near future?
Mallory, maybe we can call on Emily and Wendy. Emily's comment is a really practical one, and it probably, I think it goes to the question of, like, you know, they're at a step where, or let me let Emily unmute herself, and then we'll go to Wendy, who's asking a question about beyond PICA. What's the road like for other systems? So Emily, do you want to unmute yourself, or we can just read out?
Sure. Can you hear me?
Yes.
Thanks so much, Bethany, and thanks to all the presenters. It's been really illuminating. So I work for a large health system, New York City Health and Hospitals. We have a big MLP with NILAG that I'm sure many of you are familiar with. They're amazing. They do amazing work on behalf of our patients. We've been working for quite some time to think about streamlining referrals and scheduling. And scheduling is kind of what I called out in the chat. I'm just curious if this has been thought about in other places. It's been a little bit of a barrier for us in thinking about closing the loop because it requires ownership of that calendar management piece, whether that's on the health center side or on the legal staff side. And in both cases, there's examples where it's like not the most efficient use of someone's time. And there's pushback, I guess, is the easiest way to explain it. So we've been thinking about, like, technically speaking, is there a way to make a calendar system that's accessible on both ends so that we could sort of share that responsibility?
That's a great question. And I'm just mindful of the time that we only have 4 minutes left. So I would love to continue that conversation, Emily. I'll say it's something that I think a lot of people are struggling with. People are trying in a few different ways. Some, I think there's calendaring happening in the EHR, some happening on the legal case management side. And then honestly, I've been seeing more people use things like Calendly and outside programs that are designed to be awesome calendars. So let's mark that as to be continued, because I think you're absolutely right, and that is a huge barrier and something we want to think about, especially for a huge system like HHC, or sorry, New York Health and Hospitals. The new name. I'm saying the new name, not the old name.
And just in case we can't, I know folks are in and out of these Learning Collab sessions, as we go. So we'll make sure that, the robust response to that, maybe we can get it in some sort of succinct writing and share it. But, this is why we have this in 4 sessions so that folks can join us each time. And we are collaborating. Let me go ahead and screen share, Mallory, so we can get that lessons learned slide and then what's coming up next, so folks can know where else they would be able to. Hopefully my slides are sharing here, but we want to make sure folks know where else they can tune in to hear from at least Shannon and Mallory again about this, and know that the entire team, Dave, Aaron, Shannon, Mallory, and others as well in Montana, have really been working on hopefully a fact sheet to come soon in the next couple of months to really do a deep dive into this work. So Mallory, I don't know if you want to highlight what the lessons are, and then I'll go into just that screen about dates coming up.
Sure, and I'm gonna just turn this over to Shannon. Actually, Shannon, do you want to pick 2?
Thank
I
you.
mean, everybody can read the lessons, but Shannon, do you want to pick 2?
I can pretty much summarize it as that it is possible to kind of see the throughput of this entire process, including closing the loop. And it's going to involve work and effort and technical resources there. So being thoughtful of the patient experience overall and the client experience about how they're feeling with it in an empathetic manner, that usually lends itself to a positive implementation for this. So that's the briefest way I can do it.
Another plug, get to know your HIT friends. Get to know your HIT friends. It's really key. In addition, right, to those getting to know your legal and clinical champions on each side. I'm just going to let this highlight on the screen because I want to make sure I say thank you to Aaron, Mallory, Shannon, and Dave for really taking time out of their extremely busy schedules to share with you all additional MLP peers, what they've been working on and how it can help you advance. So thank you all, including the Learning Collaborative participants. Join us again on June 4th and 18th. We've actually continued to add more speakers, as you know. Sometimes we don't even get them, like we got Aaron today, onto the agenda to let you know in advance. But we did manage to get an additional speaker for June 4th, Andy McMahon. He's a VP at United Healthcare, Community and State. He's going to be joined by Dan Mistak. We're going to focus on justice-involved populations and do a little bit of a deep dive into like the, how do you fund this thing? We'll be talking about Medicaid. We'll be talking about correctional health as well. And then on June 18th, we'll focus on immigrants and farm worker populations. Where can you hear Mallory and Shannon again talk about this? And this is where maybe we'll go into a little bit more of what Emily asked about. You can hear them on our other learning collaborative that we're hosting jointly with Farm Worker Justice and National LGBTQIA+ Health Education Center. So on June 1st, Mallory and Shannon will join us again. And on June 15th, that's a separate registration link, and we'll share that in the slide deck that you all will receive. And we do have the issue briefs. We have the Health Center MLP toolkit as well. And we will be asking you to please, please, please let us know how well we did and what else we can do to support you in this learning collaborative. So fill out the survey. And again, we will see you in 2 weeks. It's Friday, everyone. Stay away from the cicadas or something. Have fun this weekend and stay safe. Thanks, everyone.
Take care. Bye-bye.